Good day, my dear postgraduate students. The topic of choice for the day is from Recent Advance 22 by Fred Wasman. Epithelial mesenchymal transition. A good number of output for this interesting topic was obtained from one of my postgraduate students. This is how we learn by teaching and teach by learning. A very beautiful picture that I have managed to capture from the net, which somehow masters the entire topic. So there is a blend and then there is something happening in over here. So there is a transition. Highlights and related topics. Think of the subheadings. The subheadings will take you to the topics. So I would like you people again, as usual, to spend some time with this slide. You find that there are pairs of terms that are displayed on the screen. Introduction and background. Epithelial and mesenchymal. Chronic inflammation and fibrosis. Bi-directional. So these are all some terms which actually match each other and contribute to each other. By studying it this way, we will be able to see that one topic takes us to the next. For the next about 20 to 25 minutes, I would like you people to kindly stay concentrated. The introduction is quite important by the author. Invasion and metastasis are significant. What he says is, it is not the nature of the tumor, but then its capacity to invade, metastasize, and spread that matters. Cancer cells must detach. They must migrate and they will have to reconstitute an environment for themselves. In this regard, the epithelial cells acquire some property close to the mesenchymal cells, and this is called epithelial mesenchymal transition. Also, there is a corollary or a reverse of this called the mesenchymal epithelial transformation. Because it is not enough that it just gets converted into the mesenchymal part. It cannot survive like that. It cannot do its function. Therefore, it has to again convert back to the epithelial form. There has been explosive developments in the field of cancer. We all know that cancer is devastating. And now, more and more molecular, genetic mechanisms are being unravelled. In fact, if you go into the literature, you find that each one of them is a chapter or a volume in itself. It was earlier thought that normal cells become proliferating cells. Now, it is not so simple. There is an interaction between the epithelial cell, the cancer cell, and the host tissue. And this matters more. Now, what are the characteristics of the epithelial and the mesenchymal cells? Before going to any topic, try to understand a little bit of the histology or the gross or the microscope. In this case, the cells. This is an epithelial cell. It has got three components, namely the apical, the lateral that is over here, and the basal domains. Three parts of it. The basal domain rests on the basement membrane, and it is here where the interaction between the underlying mesenchyme and the epithelial cell occurs. The lateral domain, as we shall be seeing in the subsequent pictures, forms a tight junction with each other. The apical cell, on the contrary, apical component is meant for either a secretory or an absorptive function. That is why you have got multiple microvilli which increase the surfaces. Fine. Again, you must understand that epithelial cells form continuous lining or multiple layers. When it is single, it can form a gland. So this is important. The functions are given in this box. The basal domain interacts with the basement membrane. Lateral domain, these are called as adherence junctions, tight junctions, and they are impenetrable. The apical domain depends on the needs of the cell, whether it is going to reabsorb or secrete. So this is what we had seen earlier. The brush border is for absorption, the basal domain is for interaction, and the lateral domain, E-cadherin, is meant for stability. There is a cadherin-catenin complex which gets broken. Otherwise, they form tight junctions. Now in this, what else have we seen? There is a basement membrane which has got molecules of integrin. And they may be type 4 collagens, laminins, entactin, nidogen, and proteoglycans. The stroma also can be having the fibronectin, tenacin, collagens, and proteoglycans. So in this, you find that there is a mesenchymal cell and it is surrounded by abundant matrix. There is absolutely no relation between the cells. They are rather haphazardly arranged, but there is a lot of chance for plasticity and fluidity. Epithelial cells. Now, what is the normal function that is going on as far as the spread is concerned? The author takes two tissues, namely the cornea and the epidermis, for reference. He says, whenever there is a trauma, immediately there is one mechanism called as wound healing. This wound healing also promotes fibrosis. Now you find that there is a reaction between the epithelium and the connective tissue. Also, the adjacent cells migrate and there is a change that is reflected in the cytokeratin of the epithelial cell. These have got cortical actin filaments and contractile actin myosin filaments. So this is where the interaction occurs. This reference is from this particular gentleman who has contributed a lot. So he is from the Beth Israel Deaconess Medical Center and his name is Malin Croft, professor of pathology at the Harvard Medical School. Amazing contribution. If we are not convinced, let us again look at this. This is an example of a hepatocyte. And in this, what happens is, these are the normal hepatocytes, and this will be the basement membrane. And there is a malignancy that develops. It is not simply healing, but a malignancy. All of us know the malignancy has got absolutely no control. And it spreads, breaks the basement membrane, it spreads. And then it dissolves the matrix proteins. As a result of which, finally, it enters the blood vessel. So this has been explained by another diagram earlier also. So they do not conform continuous sheets. Look at this one. This is continuous, whereas this becomes haphazard. And there is a loose connective tissue extracellular matrix. And there is no particular spatial arrangement. The cytoskeleton called as vimentin, it helps in the spread of this. And also the cytoplasmic extension, just like an amoeba, you find that there are certain structures which are projecting, which are called as filipodia. So this is a reaction between the plasma membrane of the matrix adhesion proteins and matrix metalloproteinases. These itself are separate topics which I hopefully shall cover in the recent future. Wound healing again, what happens? You find that there is a re-establishment, there is a proliferation, there is a differentiation. What does the word differentiation mean? It is resembling the cell of origin. It is a slow process, whereas in a case of epithelial hyperplasia, it is rapid, and still worse in a case of cancer. The E-cadherin is down-regulated, that is, its function is lost. Vimentin is upregulated. In the sense, it becomes more active and promotes. The cytoskeleton becomes activated and the cells migrate in groups. SNE1 and 2, they play important roles in this. Now, what is difficult for us to memorize this? Even closing my eyes, I can say that there is the cornea, there is the epidermis. And then there are the epithelial cells, there are the mesenchymal cells. There is a haphazard movement, E-cadherin is suppressed, vimentin is promoted. And you find that there is a dissolution of the metalloid matrix. And some people say that the stem cells have got a role to play. In the cornea, from the limbus, it moves and it becomes active. Now, this is the epithelial mesenchymal transition in wound healing. There is a big paragraph, but I have replaced it with a picture. You find that there is the endothelial cell. From the endothelial cell, there can be a migration. You can get what is called as a myofibroblast. Or the macrophage can change. The fibrocyte can change. The epithelial itself undergoes a transition. And the adipocytes also can change. And so also the residential fibroblast. This one, I would like you people to keep it in one corner of your mind and apply to the Ashoff module in rheumatic heart disease. What is the origin of the Ashoffs? Many theories will be given and it almost mimics this. In chronic inflammation, there are many conditions. One is the kidney. Then in any diffuse fibrosis, there is an emergence of the myofibroblast and there is a deposit of extracellular matrix proteins. Epithelial mesenchymal transition is brought about by these factors. And part of the interstitial fibrosis is done by the tubular epithelial cells. The kidney is one example that it tries to give. Obviously, you will not be able to understand. But see this one. So this is the mesenchyme. The mesenchyme is supposed to be composed of closely packed cells. This is the ureteric bud. The ureteric bud, it keeps branching. And ultimately, this will be forming the calyceal system. And this is the stroma over here and then surrounded by the mesenchymal cells. Also, you find that there is a transition as a result of which you find epithelial elements can be formed, as in the case of a glomerulus, the tubule, etc. See how beautifully it is happening, which means there is a capacity of the stem cell or there is an inbuilt property by which the mesenchyme can change to the epithelium or the epithelium to the mesenchyme. This is the earlier concept. I won't say it is too old, thanks to Robbins and the other sources. You find that there is a primary tumor. Whenever there is a primary tumor, it is composed of thousands and billions of cells. All the cells do not have the potential to invade. All do not have the capacity to differentiate. You find that there are some dark cells over here. It is these that will be having the capacity to invade. They invade and then they go inside in the form of an embolus. Along with the fibrin, the RBCs and the platelets, they form a tumor embolus. And this gets lodged elsewhere. It reinvades the wall and it gets lodged. After having lodged over there, it has to regrow into the tumor form. This is an earlier concept given in the earlier editions of Robbins, which you people must write in the spread of tumors. So also is this. So this is the epithelium. This is the underlying basement membrane and the connective tissue. So you find that there is the cadherin over here, there is a tight junction which is getting loosened. Also, the moment it gets loosened, there is a development of various substances such as collagenase and laminin. Almost like a helicopter, it lands in the helipad. So it gets landed, and no sooner as it got landed, you find that there can be various enzymes that can be brought into activity, such as the type 4 collagenase. The collagen is type 4. Therefore, you need an enzyme called type 4 collagenase. It digests the collagen and then it goes inside. Also, within the epithelial cell, there are different components. So you find that the lowermost one, it becomes autocratic and then it secretes. It is able to move inside like an amoeba. And the rest of the cell is to form. This is called migration. This is a beautiful set of explanation. But then what I was having in mind until now was epithelial cells can be replaced by epithelial cells, mesenchymal by mesenchymal cells. There is absolutely no relation between the epithelium and the mesenchyme. But here it is the other way around. In epithelial cells, there is a change in the morphology and the behavior. The carcinoma cells maintain multicellular organization. They are cohesive cells, which is the hallmark of epithelial cells. And the morphology and the expression of markers are intact. So this is the nature of the cancer cell. What am I trying to say? Look at this diagram. So this is a ductal carcinoma in situ. So there is a duct within which there is a proliferation of the cells. I find that there is a thick and an intact myoepithelium. Also, I find that the cells are all closely packed together. But later on, you find that there is a break in the myoepithelium and then there is a breach by the tumor cells. There are various immunological reactions which should not go into it. This particular diagram is meant only to show the cohesive nature of the epithelial cells. Normally, you will have to identify these things, whether a lesion is invasive or not invasive, whether it is in clusters or individual cells. Usually, epithelial cells will invade in clusters. There are a couple of exceptions. One will be the lobular carcinoma of the breast. Two will be the infiltrating carcinoma of the stomach, the signet ring cells, which can be individually placed. And there is a colonic carcinoma again. So this is the normal epithelium. There is a blood vessel over here. They are showing some amount of relationship. In an early adenoma, I find that there is a proliferation of the cells. They become piled up, but then still some amount of regularity is maintained. So there is an increase in the B-catenin and there is intracellular activation of these substances. If possible, you just have this in mind. Clear. But then there is one element called the cancer stems. So look at this one. These are all cancer stem cells which come into action and there is a proliferation of this. So it is not just epithelial cells that are proliferating. There is a stem cell that helps in the proliferation. Once it goes to the stem cell, there can be an element called as de-differentiation. It becomes something more primitive and then it can go in another direction of the mesenchymal tissue. So this is a progression of the colonic carcinoma. So different in the case of infiltrating carcinoma of the stomach and lobular carcinoma of the breast. Now, my dear students, this is a picture of a squamous cell carcinoma, oral squamous cell carcinoma. I always concentrate on the pictures and I avoided the text to make things easy for you. This is the normal squamous epithelium. There is a basal layer of, and this is the basement membrane. And when a malignancy develops, you find it invades the basement membrane, breaches. And you find the change in some of the tumor cells. You find that they become active. There is a change in the cytoskeleton and it can start going down. Also, various other factors such as the growth factors come into play. And this will be the mesenchymal element that are there. Also, angiogenesis is being promoted. So there is a lot of active play that is going on rather than a static situation as we see in a histopathology slide. This is a very important picture. I would like you people to kindly memorize it. Very important. Again, I'll be slow. Epithelium over here, mesenchymal element. So there is epithelial mesenchymal transition. And this can be bi-directional. Look at the direction of the arrows in both sides. Now there are three columns: markers, regulators, and markers. These will be the markers for the epithelium. There are many things that are given. Cytokeratins, E-catherine is extremely important, laminin 1, etc. And there are some regulators. These regulators we shall just be noting down, such as transformation growth factor, beta. Then also the vascular growth factor. In the mesenchyme, I have got other elements such as N-catherine, P-catherine, and vimentin. These will be promoting the change. They will actually be getting more activated, whereas these will be getting less activated, and this is called as dedifferentiation. Also, you note that these markers are non-motile, non-invasive. In fact, they prevent the invasion. Whereas these markers are just the opposite of it. Non-motile means it is motile here. Non-invasive means it is invasive here. And these are nothing but molecular proteins which are there. So this particular table, I would like you people to kindly memorize. And mRNA are supposed to be, again, molecular proteins which can either inhibit or promote epithelial mesenchymal transition. So all the numbers below you can forget, but the larger boxes I want you to kindly memorize. See what is happening. The epithelium acquires mesenchymal features such as motility, invasiveness. It develops a resistance to monoicus. Monoicus actually it prevents the penetration, whereas it develops a resistance. Signaling pathways are being activated, and several mRNAs have been identified. And this is from this particular reference. You people can go to it. So vimentin. E-catherine is supposed to prevent. N-catherine, it actually promotes. So also vimentin. And look at this one. This is a tumor, and in some cases, in the early cases, this is the epithelial element of it, and it has already invaded the stroma. But then there is not much of this vimentin over here. But then, as it becomes more aggressive, you find that it is strongly positive for vimentin. It is a case of pancreas. I think even the endometrium or the cervix can be classical examples of this. The epithelial plasticity is bi-directional. I've already mentioned that. So there is an altered behavior in the morphology. There are various pathological conditions such as hyperplasia, wound healing, etc. and cancer. And after invasion, the metastatic cell reaches the target. Now, what is important will be the same infrastructure is needed again. And this is for the re-establishment of the histology of the tumor. Again, when you see an infiltrating tumor, you will be seeing the glands. You will be seeing the basement membrane, which is being laid down by the tumor cells. And the action is opposite to epithelial mesenchymal transition, and it is called as mesenchymal epithelial transition. So in this case, the opposite happens. Earlier, E-catherine was down-regulated. Now E-catherine becomes up-regulated. Adherence was not there when invades, but then it becomes re-established. The cytoskeleton was very active and dissolving, but then it goes into the resting stage. All the opposite of the first step happens here. So it should not be difficult for you. I understand it is a weird topic, but keep on repeating this one, it is easy. The E-catherine is incapacitated in diffuse carcinoma and in a lobular carcinoma. That is why I find them as individual cells and this gland formation is not possible. The epithelial mesenchymal transition. This picture I have shown you already. So there are two terms. One is EMT, other is MET. So this happens during the protein embryogenesis of the kidney. I have already explained this. I have put the picture side by side so that you people recollect what has been said. Now, what are the cellular modifications associated with epithelial mesenchymal transition? So these are all the important headings which I would like you people to kindly memorize. What happens to the in vitro morphology and function? What are the down-regulating proteins? What are the up-regulating proteins? What are the activated proteins? And what are the nuclear expression proteins? Morphology, and both are actually common columns. There is only two columns over here. For want of space, I have put it. So you find morphology, it becomes stellate or spindle shape. There can be invasion of the collagen, increased migration, etc. Down regulation of the proteins will be E-cadherin, cytokeratin, occludin, claudin. Up regulation can be N-cadherin, vimentin, SNAI1 and 2, twist. And activated proteins can be interleukins and GSK3B. Nuclear proteins are B-catenin, SMAD2, 3, and SNAIL1, SNAIL2, and twist. So this is the one that you people can remember. Even if you can mention about 3 or 4, you are an excellent student. But definitely, I think you'll be able to mention almost 50% of it by heart. There are some signaling pathways. So to compare with the morphology of the normal cells, both in physiology and in pathology, there is an intrinsic biological process that is going on. So this is again a beautiful diagram. This is a reference over here. Beautifully drawn line diagram. The image credit will go to this particular person. So he has mentioned the epithelial phenotype, the epithelial cells, and the epithelial markers over here. And then there is a transition. What happened? This is a pathway or the intervening, something like the enzymes. They promote these things. See what is happening over here in the mesenchyme. The epithelial phenotype, mesenchymal phenotype, mesenchymal cells, and mesenchymal markers. The sets of markers, already we have seen this one list. You people will have to memorize, have at least 3 or 4 in mind. Cell additions are there, loss of additions. Polarity is being maintained, there is a loss of polarity. Type 4 collagen laminin matrix, and there is a break of this collagen and laminin. Non-migratory, migratory. What more do you people want? What is the microenvironment? We are living in a miniature world. So there is a response to the microenvironment, and the responding cells have got some receptors, etc. So it is too much. And probably what Einstein has said is this. This man was supposed to be, or even now, in literature, he has got the highest IQ. The normal high IQ is supposed to be 7 or 8, but this man's score was 21. We shall require a substantially new manner of thinking if mankind is to survive. So, dear students, if you people want to survive in future, you will have to develop a different line of thinking. So, what is the role of E-cadherin? So, E-cadherin, just like this epithelial markers, these are all the things that we have mentioned. So, you find that there is an activation of the transcription factors such as these. And ultimately, you find that these are getting converted to. And what is the function gain? Function loss. You people can mention it for the time being. So, E-cadherin is one. There are many complex pathways. When you say just it is not snail or slug, for each of this, you find that there would have been a research behind it and a panel of articles there. So it is not just one topic. There is a B-catenin being liberated, and then there is a cadherin-catenin complex, and these are all being altered by means of the central regulators. Change into this mesenchymal markers. Another one, cadherin is one that we people should mention. The second one will be transformation growth factor. So there's a transformation growth factor. See the excellent function, the scope of it. It can be in metastasis, or it can be in the immune system, or it can be in the conversion of epithelial mesenchymal transition to the mesenchymal cells, vice versa. There can be the activation of angiogenesis, apoptosis, as well as the normal proliferation of the cells. So this is the function. Transformation growth factor by itself is a question for you people. If you people can have this in mind, go back to any of your books. I think it will be of great use. And it has been now found that they have got the stem cell properties. I have already shown you in the previous pictures of the kidney and then the basal layer, etc., de-differentiation, etc. So there is a budding pattern, and then the tumor cells are held together by means of e-gathering. There is a loss of it at the invasion site. And the stem cells also have the invasive properties. So it is not just the loss of the property, but also the stem cells that are coming into action, which can be playing out. So I think you people can recollect the diagram on tumor invasion. This again is a super picture, mesenchymal epithelial transition or epithelial mesenchymal transition. So what is over here? It doesn't talk about the substance as much, but then it is polygonal, columnar in shape. This is the apical domain, this is the basal domain, lateral domain. It is being well knit. There is a strong cell-to-cell adhesions, and there is a limited potential for migration. The mesenchymal cells, these are all the actin and the myosin filaments capable of moving in any direction. Lot of matrix is there, and it can swim around. Spindle shape. Polarization is antero-posterior. And it is only in focal region that there will be a cell-to-cell contact, whereas here there is a strong cell-to-cell action. And the markers for these are pymentin, N-cadherin, fibronectin, E-cadherin, cytokeratins, acludin, and claudin. What more do you people want? It's a beautiful one that I am presenting. So the summary is, again, the set of markers we people shall remember. There is a epithelial mesenchymal transition, and this is a mesenchymal prototype. And what are the markers for this? What are the markers for this? You people will be able to write your own story. Obviously, study this. The importance of epithelial mesenchymal transition. It is not just invasion and metastasis. Why do you want to study the invasion metastasis? Because it will show the nature of some of the cells. Further work can be done based on the initial work. Diagnosis can be made. Drug therapy. There can be something called as targeted therapy that can be done. Then there can be some application between the invasive and the non-invasive tumors. What is the line that is separating them? Immunohistochemistry, what can be used? So these are all the other things. Studying the nature, what is the difference between them, developing further ideas, the usefulness of drugs, and immunohistochemistry. And these are all the markers that we people should be having in mind. Drugs are cytostatic. It can be used in diagnostic histopathology and epithelial growth factor inhibitors in lung cancer. These are all certain things that are being studied. Probably they are already in action. You people can go to the literature and see. The worst distance between two people is misunderstanding. I think I have given you enough information, or rather, a school of thought for misunderstanding. And our misunderstanding of pathology shall continue.